Hi, I'm Jim Collins. I'm Director of the Communicable Disease Division at the Michigan Department of Health and Human Services. My story from the field addresses electronic laboratory reporting. Electronic laboratory reporting has been in place in Michigan for a number of years, and we've been very successful in bringing information into our surveillance systems with electronic lab reporting, or ELR. One of the issues with ELR that was identified was a real limitation on the amount of information that was addressing our race and ethnicity. And those are critical variables to understand when we want to look at things like health equity in the state of Michigan. What we did was to try to look at improving it at the laboratory side. Looking at health equity with our laboratory reports, we could see things, not only the positivity in these communities, but also the distribution of testing. Now, equity involves the delivery of services as well as the impact on the population. And with the identification of limits in delivery of services in certain populations, we were able to bring things like testing centers and testing clinics to underserved populations. The volume of reports that were coming into our system was overwhelming, partly because we were receiving both positive and negative reports. Those were critical indicators for the community, but also a lot for a system designed to process only positive reports, to take in referrals of diseases. We developed a solution, and the solution for that is to bifurcate the messages when they came into the state of Michigan. We were quickly able to generate daily reports on positivity in different communities, and as well as the distribution of testing across our multiple geographies in the state of Michigan. The rapid reporting available using this open source product allowed us to address real-time demands for data that really were unprecedented in recent years. And so being able to tell where the testing is and what the results are in an aggregate form very quickly helped us a lot in addressing public health needs. We're moving forward on a lot of fronts. It's important to consider that we need to sustain that level of investment. We need to sustain this level of collaboration between jurisdictions. All of the things that were improved over recent years are only going to stay if we can continue to support them with resources. So the transition we're seeing in data processing for public health is huge. In our state, coordination between immunization registries and disease surveillance systems and vital record systems. And then looking at that in terms of opioid abuse, and looking at it in terms of chronic illnesses and all the things we can pull together now because of the tools that are now available. That's exciting for me because it creates an environment where public health can be more impactful. The last several years have been incredibly hard on public health. We know that. It's been a struggle. In the big picture, I don't think public health has gotten the same recognition as first responders or healthcare workers, and I think they should. I have been amazed by the level of effort our staff at MDHHS has made, but also the level of effort that my colleagues that I've established over the years through CSTE, and I consider them some of my best friends in the whole world. And we share so much in what we do, but also what we feel and why we're doing this. The things that kept me going were my team at MDHHS, who never quit, and my friends at CSTE, who never let me down.